it also lives up to its name. So you will see that the autoimmune disease usually happens in like in a with other autoimmune diseases. Your patient usually is a female. Female has all autoimmune diseases, even though this is probably changing now as a result of the explosion of the number of autoimmune diseases around the world. And what you're going to find is that there will be no viral marker. This is what you would worry about the most, especially Hep C in the US. If you're in the US, in the rest of the world, it's still Hep B. And what you're going to be finding is that there is an elevation of the immunoglobulin, especially the immunoglobulin G. So IgG is going to be pretty high. And then you may see actually some autoantibodies that are directed against different parts of the hepatocytes. There is increased frequency of specific types of HLA, the D8 or the DRW. And like I mentioned to you, it happens with other autoimmune diseases. This is where you can actually get clues when you're trying to answer a question. So they will tell you that the patient did have actually a recent diagnosis of vitiligo, for example, or type 1 diabetes or Hashimoto's. So those autoimmune diseases usually happen with each other, as a group, that will present. All right, alcoholic liver disease. The slide that I did not want you to touch is this one right here, the alcohol toxicity. Okay, this slide, came from internal medicine. I was asked to add it, but honestly, I don't think it has any space here. The only thing that I want you to know when it comes to alcohol toxicity is that it does have actually a direct effect, especially on the mitochondria of the hepatocytes. So much so that it will deplete actually any kind of reduction ability of those cells to deal with the ensuing injury. Not only this, this is a chronic abuse. So, if it's happening that, the patient was able to deal with it at the beginning as a result of the chronicity of the problem, as a result of the chronicity of the abuse, this is not going to be the case after a while, of abuse. And as a result of that, the injury is going to become even more pronounced. So what you're going to be finding is that, it will go through stages. So the first one is going to be actually the steatosis, the fatty change that is going to, engulf the liver, as a result of the alcohol abuse. And that actually, if it continues unabated, it may actually turn into a cirrhosis, into a fibrotic and then cirrhotic liver. Now, there are stages at which, you may go back to normal. At one point in time, as I mentioned to you before, we saw that cirrhosis is an end game, meaning it is the wastebasket that everything ends up in, from which there is no recovery. We are finding out that this is not really completely true. And there are stages in cirrhosis, especially the very early stages, where if you stop actually the ensuing toxins, the patient may go back actually from cirrhosis to, what may be, considered as normal, lobular architecture. So that's in the very early stages of cirrhosis, and also, when you are still in the steatosis, stage. As time goes by, if this continues unabated, and there are actually those nodules that has formed, the end result is going to be that, there is no coming back from the cirrhotic stage, and your patient is going to succumb to this, end-stage liver disease with all, the clinical constellation of end-stage liver disease, from jaundice to anasarca to hepatic encephalopathy, and coma, and possibly also death. All right. One thing about actually the stages that the liver goes through when it is affected by steatosis in general, not just the one that is coming from the alcoholic injury, is that in the early stages of the disease, when there is steatosis, what happened to the liver? Is it small or is it big?
Big.
It's going to be big, really. If you try to examine the liver, you will see that it is several fingers below the costal margin. Now, as the disease ensues, and as the fibrosis sets in, and then eventually cirrhosis sets in, what will happen to the liver at that stage? It will shrink, actually, right? It will become very small. So at that stage, they will tell you that the liver is not palpable. It has gone actually smaller, and as a result of that, even with your best clinical examination, you will not be able to figure out where the margin of the liver, where is the edge of the liver. Here's an example of that. Usually those livers that are affected with steatosis, whether again from alcohol or actually from fat, just fatty liver that becomes eventually NASH, the non-alcoholic steatohepatitis, usually are huge. The ones that I used to receive used to be 4 or 5 kilos actually in weight. You need really two hands to carry it, and it is very yellow, which is the color of fat, when it is cut. Here is actually, as you can see, the fat liver. Thankfully, there's still no fibrous septate. So if this patient, started to take care of business, whether from diet or actually from stopping alcohol, there may be actually a recovery. There may be return from this to normal. Here's an example of that, where you start to see the infiltration of the fat, in all cells, micro and macrovesicular steatosis. And in addition to this, you start to see that there is ongoing injury that manifests itself with this fibrous septate that are actually extending from one end to the other, from one portal tract to the other. Now, what you're going to be finding is that the cell of interest, when it comes to alcoholic hepatitis, it is actually going to be the segmented neutrophils. All right, segmented neutrophils that are going to take care, of those, of this infiltrating foreign material in this case, which is the fat that is engulfing the liver. So remember this: the cell of interest in alcoholic hepatitis is actually the neutrophil, the segmented neutrophil. In addition to this, as a result of the ongoing, injury that is happening to the hepatocyte, there will be degeneration of some of the cytoplasmic, organelles, resulting in the creation of what is known as Mallory-Hyland structures. Mallory-Hyland structures, which is an intermediate cytokeratin filaments. It is not diagnostic of alcohol-related liver disease because you may see it in others, but it is highly suggestive, especially in the right clinical setting, from the history of the patient, and also from finding the other features of alcoholic hepatitis with this infiltration of fat and also the presence of the neutrophils in the section. So the Mallory-Hyland is not really diagnostic, but it is highly suggestive of alcoholic liver disease. Now, the end result of that is going to be the cirrhosis, as you can see, micronodular cirrhosis, where you see these nodules of variable sizes that are crisscrossed with this fibrous septate that separates it. As I mentioned to you before, the cirrhosis that you see in the liver, whether it is the etiology is alcohol or viral or anything else, it is a defense mechanism from the liver itself, trying to protect what seems to be still surviving nodule. Now, this nodule has survived the process. Those cells have not died yet. So the liver will try to surround these nodules with this fibrous tissue. Now, in the process of doing so, especially in the area near the fibrous tissue, you will see that there is no relationship that is left intact between the hepatic course and the hepatic sinusoids. And that's a very critical, actually, relationship. Why? Because it is from the hepatic sinusoids that the liver cells are going to be getting their nutrient. Once you put, instead of the hepatic sinusoids, you put in fibrous tissue, those cells at the boundary especially will start to die. Why? Because they are no longer able to dig into the nearby nutritional supply that is present in the sinusoids. And the end result is going to be more death. Now, how does cancer actually come back from this or originate from this? It is simply, when it comes to alcohol injury and alcohol-related liver injury, first, there is a toxic effect and probably also a carcinogenic effect on the liver cell. This is number one. Number two is that you will see that as a result of the death and then rebirth, or regeneration of those cells, what's happening to the cell cycle of those cells? The cell cycle is increasing, right? And when the cell cycle increases, that is going to result in actually not being able to control the cell cycle like the cell used to do during normal times. And as a result of that, mutations actually may enter into this equation, may escape actually the very vigilant mechanism of detecting mutations in the cellular genome that is employed by the p53. So the end result is going to be that some of those mutations are going to enter into the cell cycle unnoticed, And the majority of them are going to be actually mutations that will mean nothing, meaning they will never be translatable. They will never end up in nothing except liver cell death. But one of them may be actually resulting in transformation that may give rise, to a tumor formation. Go ahead.
Doctor, I'm just going to ask.
Can you speak up, please?
I was just going to ask you the Mallory Harlan. What did you said something about it being
Right.
described?
It is a cytokeratin, intermediate cytokeratin filaments that results actually from the degeneration of cytoplasmic organelles. It may not be found only with alcohol-related disease, because you may see it in other entities as well, in other diseases as well, but it is highly suggestive, especially in the right clinical and pathological setting. All right. Yes?
I have a question. How molecular and cirrhosis will be a defense mechanism?
How the cirrhosis will be a different mechanism?
Defense.
How's it? I don't understand the question.
Defense mechanism.
How does cirrhosis go to protect
Right, the cirrhosis is going to protect, at least it is a different, because there is an ongoing injury, right? Where is the injury coming in this case? Where is the injury coming? In the blood. In the blood, right? So it is trying to protect the surviving hepatic nodule from the blood. Where is the virus? Where is the virus infection? In the blood. It's coming in the blood, right? It's coming to the liver cell to become inside the liver cell, but originally it is in the blood. So when there is a fibrosis surrounding it, it's protecting it from actually access to those surviving hepatocytes that are present, protecting the surviving hepatocytes from their from their reach into the blood. Because in the blood there is the virus, you see. And pretty much everything. Also, if there is iron, for example, where is the iron? Also in the blood, right? So when it tries to actually shield the surviving hepatocyte, it is because it's trying to shield it from the toxic effects of whatever that, or the viral effects of whatever that is in the blood itself. Okay?
Doctor, so you mentioned that the cells in the periphery, they can't reach the nutrients and they're going to die and regenerate.
Right. But also that happens within the nodule itself.
Yeah.
So that's not just limited to the periphery. This is really ongoing, because the total normal architecture of the liver is going to change, meaning you no longer have actually a single or two file thickness of hepatic cords. Rather, you're going to be having several, not as much as you see in liver cell cancer, in hepatocarcinoma, but you will see it thicker than normal, and that will affect even those actually hepatocytes that are present within the nodule itself. So this process is really ongoing. But go on.
Yeah,
That's it. Okay, good. So amazing enough. I surprised myself. Anything else, guys? Did you get the hang of it somehow, somewhere?
Yes.
Hopefully, yes. All right. So here's what I did, just to show you that we do have actually, at least me, I do have a heart for our students. So I combined the last two lectures. Otherwise, I would lead 1 hour today and 1 hour later this week. I combined them in one. And you will see, how does that come to happen? Because if you start with biliary disorder, you may easily actually delve into biliary cirrhosis, which was the third lecture. So I gave you last time, on the assistance of your BLC, I sent you the 3 lectures, right? So the third lecture, do not touch. The third lecture, this will be here in lieu of the third lecture. Okay? So make sure that this is the one that you read, not the other one. All right, so now let's talk about cholecystitis. Let's talk about this, structure that is there, that is housing, the bile, and that is going to be affected with variable kind of, diseases, starting with, acute and chronic, and then acute superimposed on chronic cholecystitis. Now, it is the most, imagine this, it is the most common indicator for abdominal surgery in the US. That tells you, how bad it is, really. Now, when you are actually in the gallbladder and you say the word gallstones, you're going to be right, because that's really the most common and the most important, common denominator, of all diseases that affect the gallbladder, including actually, carcinoma. Okay. So what's happening is, the question is, how does gallstone come to happen? Gallstones do not happen in normal conditions for a simple reason. The cholesterol that is present in the bile is kept in a soluble, in a solubilized, version, in a solubilized form, okay? How does that happen, you guys, from your, your very strong memory of year one? How does actually the cholesterol that is kept in, in the bile stays in a solubilized form? By the bile acids, right? So the bile acids will act actually as a detergent, right? Detergent effect on the cholesterol to make sure that it keeps it in a solubilized form. This is not the only actually reason for that. There's another reason why it is kept in this form. How is it kept actually? How about this? Let me ask you this. How is it kept in the bile? Micelles, right? So and what is the micelle?
The bile acids are going to form ball kind of structure.
Can you speak up, please, so that the boys also hear you?
The bile acids are going to form a ball-like structure, and the cholesterol is
Ball-like structure. I like that very much. Wow, beautiful. Okay, so it is kept actually in the micelles, which are this smaller structure here, which is made up of actually bile acids and lecithin. And it is actually two ends, right? One end that is a polar end that towards the aqueous on the outside, and the second end, which is the non-polar, end that is actually present within. The cholesterol in the micelles is kept in this end right here, in the middle of the micelles, right? It is kept in a balanced, balanced form. Okay. Now that's actually one way for this to happen. The second, way for storage to happen, of cholesterol in the bile is in the form of vesicles, larger actually structure than the micelles. It's made up of mainly actually phospholipids, the lecithin, and it is bilayer actually of, as you can see, instead of single layer, there are two bilayers here with one aqueous, end that is one polar end that is facing the aqueous environment on the outside. Okay, where is the cholesterol kept in this way? It is kept at the non-polar end right here. Also, it's kept in a balanced, actually, form. Now, what's going to happen, is that if the cholesterol, so as long as there is a balance between the cholesterol and the bile salts and phospholipids, the cholesterol is going to be kept in a solubilized form. When this balance is going to tilt in favor of the cholesterol, meaning you have more cholesterol than bile acids and phospholipids than normal, that equation is going to be shifted, and those actually structures will become unbalanced. And those unbalanced structures are going to start, instead of actually repelling each other, they will start to aggregate on each other, creating multilamellar structures that is going to start to crystallize to form actually the basis of the gallstone. Okay? That's a very important thing to keep in mind. So the question now is, how does actually cholesterol increase? And the cholesterol increase, you would think that probably the first thing that should come to mind is that this is related to diet, correct? Actually, diet is really is there for sure, but it is not number one. The increase in cholesterol, how about this, pudding or secretion, let's use the word secretion even though it's not really that, it should not be, imagined and it is secreted. The putting of this cholesterol into the bile, the increase in the putting of the cholesterol in the bile is a primary, kind of phenomenon, a primary, defect, if you will. Meaning it happens, what primary means in medicine, right? This is when you throw your hands in the air and you say, I'm not really sure how it happened, that's one. Two, that primary actually could be related to genetics. It's known actually that the white race will put more cholesterol in the bile. One of the few times where you see that the bile race is a risk factor actually. This is really a reality. This is one. Two, actually sex. Is it males or females who are going to be putting cholesterol in the bile? It's going to be mostly female, right? Okay, how about actually age? Is it usually the young or someone who's 40s and 50s? 40s and 50s. So you remember this, the 4 F's? The fat, fair, fertile, and what else?
40.
Fat, fair, fertile,
40.
and 40. Thank you very much. Yes, so, those are going to hold true in this case. There are other actually reasons why this may be, happening, including some drugs, that may be related to this, that could be related to the, putting in more cholesterol that are going to tilt the balance in favor actually of, forming, a micro crystal, the micronuclear, structure that from which the goldstone is going to form. Now, once that micro, calculus structure has formed, this is not actually going to be the end of it, because there should be what you call a carrying, medium. The carrying medium is going to be the mucus that is going to be secreted by the epithelium lining the gallbladder. Okay, that is going to start to collect those actually multilamellar, micro, calculus, if you will, together, and that's going to eventually form the, the structure, of the gallstones. Okay, where 90% of the structure of the gallstone will be cholesterol.
Doctor, I was thinking, or I was expecting stasis was the main cause of crystallization of the cholesterol.
Well, it is part of that. Stasis will be there, as you can see. That's going to result, in some actually pathologic changes in the gallbladder wall. But amazingly enough, actually, I would not think that stasis. I would think that if you eat more and you put more, cholesterol, I think this is the logic thing, right? But if you go and read, it is really related to this primary kind of defect of increasing cholesterol putting into the, into the bile, and that's going to result in the tilting this, balance. Anything that is going to tilt this balance is going to be resulting in the formation. But stasis will be part of it as well. Probably not as important as the rest, but it will be there as well. Okay. Anything else? All right. So did you guys get the hang of it? Did you study it in year one? Let me ask you this. It's important to know that. Have you studied it in year one?
Yeah.
Okay. Did it make more sense now than in year one? Probably, right? Because you're reading it in context now. Okay, so acute calculus colitis. Where is this happening? This is happening actually as a result of a stone that has moved forward. A stone that is present in the body of the gallbladder. The person eats. The gallbladder will contract under CCK. And that's going to result actually in moving this stone with the rest, of the bile, and the stone is going to get impacted in the neck of the gallbladder. Now, the neck of the gallbladder is actually a pretty narrow space, and in that area, what also is going to be passing is the cystic artery. Okay, so that actually is going to result in first ischemia. That's going to result in increased tension of this, of the gallbladder, and eventually, actually, that's going to result in inflammation, of the gallbladder. If this continues elevated, there is a chance actually that the gallbladder wall maybe become necrotic, and that may result in rupture actually of the gallbladder. Now, what is the fate of this stone? The stone actually could do one of three things. It could move forward with the flow somehow. Actually, it will move forward with the flow and go with the with the bile and into the common bile duct. In the common bile duct, there is a chance that it will also impact the common bile duct. In that case, jaundice will happen, and you will start to see cholangitis in this case, which is inflammation of the bile and also of the bile ducts, the common bile ducts. In this case, it may move backwards into the gallbladder, and with time, the inflammation is going to subside. Or actually, it may become impacted deeper and deeper, and in this case, that's a pretty, probably the worst kind of outcome that you would hope for, because there will be severe ischemia that will be compounded with this pain that, as a result of the impaction in that site, there will be, there may be gangrenous, changes in the gallbladder wall, perforation of the gallbladder wall, and the biliary kind of peritonitis, that will result in one of the most fatal kind of complication that you would think may happen in the abdomen. Okay, so one of three things may happen to the gallstone. Now there is the acute cholecystitis, the acalculous cholecystitis, that will happen in the absence of of a gallstone. You will see that the overarching denominator is going to be something related to a debilitating state that is related to ischemia. So ischemia is going to play a very important role in this case. You mentioned stasis right here. That's actually where you see it. You will see it more with the acalculous kind of cholecystitis. You won't see the stone actually, but you will see that the bile itself is all that is needed to create inflammation in the gallbladder wall. I did one time actually an autopsy on someone who had a bile leak. They were doing anastomosis between the common bile duct and the intestine, and there was bile leak that they figured out later. So it really went into the abdomen and starts to eat all the tissue. The tissue of that person, there was no abdominal wall in that person. So instead of cutting it, it was already open from actually the bile leak that happened. This is how powerful it is. So it is going. This is simply what happened also in the stomach, if you recall. The stomach has so many defense mechanisms to protect against not really other offending organism, but against its own acid. Similarly here, it is the bile acid that is going to be concentrated as a result of the stasis that you mentioned that will take care of business in the acalculous form of cholecystitis. Okay, so it figures more prominently with acalculous than with calculous cholecystitis. Now, once that happened, once you have actually this kind of stasis, whether it is due to a calculus or whether it is due to simply stasis and inability to contract. For example, you put the patient on hyperalimentation protocol. You deliver it to the intestine. You deliver the food to the intestine. So you no longer actually having this. You no longer need this contraction of the gallbladder. Stasis will happen, and what happened with stasis happen anywhere in the body. Infection is going to be setting in, right? So infection may set in, and bacterial, overgrowth may happen, and that can result in further complication for this patient. All right, now chronic cholecystitis. If this becomes, if this goes on unabated and attended to and treated, it may result eventually in turning this acute cholecystitis, form of the process into chronic cholecystitis. Now, the hallmark, the difference between acute versus chronic is that the chronic cholecystitis gallbladder wall will be what? Will be much thickened. It will be replaced by fibrous tissue. So there will be so much fibrosis that even when this gallbladder receives hormonal input in the form of CCK to contract, will it contract? It will not really, because it no longer will have this ability to overcome this amount of fibrous tissue that has accumulated in its gallbladder wall. All right. Now, what happens also to the mucosa? The mucosal layer of the gallbladder will become flattened as a result of the ongoing inflammation. Now, this inflammation actually may not need for any kind of calculus to be present at the neck of the gallbladder. Those calculi that usually are plenty, there are many of them, very numerous, number of calculi, usually cholesterol calculi. You will see them sitting next to each other in the gallbladder wall in a way what you call actually fitting each other like a jigsaw puzzle. And there are so many of them. They are in direct continuity with the gallbladder wall. What happened to the gallbladder wall in this case? It will become inflamed. So you don't need actually for the inflammation to happen as a result of ischemia. It may happen simply as a result of the ongoing irritation from the gallstones that are present nearby. All right, cholangitis actually is going to be the inflammation of the bile and of the biliary duct, that are carrying it. Now, how does that happen? The question that should come to mind that actually the bile itself, as I mentioned to you, a very corrosive kind of substance, should be taking care of any kind of bacterial overgrowth, correct? Any kind of bacteria that finds its way into the common bile duct from wherever it is. Probably something that is going to be common is if you do any kind of stenting, if you do any kind of ERCP procedure under non-sterilized condition, that may introduce bacteria into it. Would you worry about actually bacterial overgrowth? You should not worry about bacterial overgrowth in the common bile duct. The reason for this is that there is the bile that should take care of any kind of bacteria or any kind of infection. So when do you think it's going to be a good time for bacteria to grow into the common bile duct?
When there's a stone that is in.
Excellent. So when there is an obstruction, right, of the flow of the bile, that's it, right? Then the bacteria will have a field day with the common bile duct, and then it will go through this obstruction into the rest of, because imagine the common bile duct is now itself inflamed. This the obstruction will not stop it. It will spread above, and it may go into the liver. And when it goes into the liver, it may result in retrograde flow of bile. What will happen when you have a retrograde flow of bile into the liver itself? What happened to the liver cells? They will become destroyed, actually, right? Where this process will happen, where do you think the bile lakes are going to form in the liver when that happens? In the portal tract, right? Where you see the common bile, ducts, right? Where you see the ducts, the bile ducts with the hepatic artery and the portal branches. All right, so that's what is known as ascending cholangitis. Okay, something very important to know, that where does it come from? It's going to be the most common site overall, the most overwhelming common site from which it will come is going to be from the GI itself. So it will cross the ampulla vater into the lower common bile duct, and if there is bile, bile will not have a chance to survive. But if there is obstruction, then the infection is going to happen, and it's going to engulf actually the whole structure and into the liver, upward. Okay. Now, when that happens, first, one thing I want you to know, in case I ask you about it in the exam, which is the clinical manifestation, known as the Charcot's triad. That manifests with fever, jaundice, and right upper quadrant pain. Remember that. Now there is also, there is the Raynaud's pentad, where you have to add to it, the hypotension, and also the confusion that is going to emanate from the septic shock that the patient may actually, may develop as a result of the sepsis reaching the blood, as a result of the bacteria reaching the blood. Okay, so remember the Charcot's triad and the Raynaud's pentad that is related to it. Now here is actually the connection to the lecture that I told you. Please read from here and not read from the other. So now imagine actually that there is an obstruction to the common bile duct, and that the bile now is flowing backward, upward into the liver itself, resulting in destruction of liver of liver cells. First in the portal triad, and then, like everything else, it will communicate to a nearby portal triad, resulting first in bridging necrosis, because the cells will die as a result of the exposure to the bile in that region, and then bridging fibrosis, and then eventually cirrhosis. What do you call this cirrhosis? You call it biliary cirrhosis. Why? Because it emanates from the bile, right? So you only put the name on it that is related to the etiology that from which it resulted. Now, what is the most common cause of this? The overwhelming most common cause is going to be the extrahepatic cholelithiasis. Okay, the extrahepatic cholelithiasis that is present, in the common bile duct. Now, anything else could be any kind of compression actually on the common bile duct as a result of a tumor nearby, either a tumor within the common bile duct, there is a common bile duct carcinoma, or actually a tumor in the head of the pancreas that may actually impinge on the common bile duct, resulting on obstruction. It may be resulting actually from a fibrotic repair that happens nearby, inflammation and fibrosis that may pull the common bile duct to it, and that may result actually in obstruction to the flow of bile. The bile will start to flow upward, and that's going to be it. Now, in children, you go and look for more congenital kind of causes, including biliary atresia, cystic fibrosis with the very thickened kind of secretion may cause it. The secretions itself will act as a plug, actually, as an obstruction to the flow of bile. Any kind of cystic structures, that may obstruct the flow of bile, or also a syndrome known as congenital paucity of bile duct syndrome. So 3 congenital causes, and one that is definitely has a congenital basis for it, but it is related to the flow of bile and the the thickness of the secretions that you see pretty much everywhere with cystic fibrosis. Now the end result will be what? The end result is that this bile is now flowing into the liver and destroying the liver, turning it into a piece of wood, really. It's gonna be so hard to cut it. It's probably the hardest type of cirrhosis that you will see in or affecting the liver, the one that is related to biliary cirrhosis as a result of the intense destruction that happened. All right, and as a result of the destruction that will happen in the area nearby. All right, so as you can see here, there is also very yellowish, greenish color. Where does that come from? The bile itself, right? The bile is yellowish, greenish, and as a result of that, it will take the color of the bile because that's what caused it in the first place. You take a section of that, and you will start to see again the same, end, diagnosis, if you will, that you see with all other entities, including the formation of those nodules that are actually what you call regenerating nodules. All right, now primary biliary cirrhosis, the same exact process that you will see here, retrograde flow of bile actually into the liver, but in this case it is not resulting from cholelithiasis, rather it is resulting from an autoimmune destruction of the intermediate and small bile duct. So as a result, so if you think about the liver as a structure and with many layers, right? What happened, how does the bile flow? The bile flow from up towards down, right? On its way into the common bile duct and into the GI. What will happen actually if the lower levels of the liver, those bile ducts that are present in the portal tract are destroyed? The bile will come down and it will not be able to come down, right? It will flow upward, it will flow backward. It will into the rest of the liver. That's exactly what happened in primary biliary cirrhosis, and that also what happened with primary sclerosing cholangitis. Exactly the same process, but with different etiologies. The primary biliary cirrhosis here, it is an autoimmune, both of them autoimmune in nature. Okay, this one here is going to result in actually turning again the liver into a piece of fibrous tissue at the end, so there will be cirrhosis. Now, if you look, who is your patient? That's probably a slight difference between the PBC, the primary biliary cirrhosis, and primary sclerosing cholangitis. Your patient in this case is going to be a woman, a middle-aged woman, 40 years of age. And how will be the presentation? The presentation will be with fatigue, 65%, and pruritus. Pruritus, the presumptive etiology of the pruritus is that the bile salt, again, presumptive, not really set in stone, is that the bile salt will find its way actually into the skin, and that may result actually in this kind of presentation. Now you will see all the features of end-stage liver disease when the cirrhosis is going to be there at the end of the disease, including the anasarca, including the jaundice, including the hepatic encephalopathy and coma and death probably. So the death in those patients will happen resulting from liver failure, with massive varicose hemorrhage. If you have done actually the case of the PVL from last week, those hemorrhage that you see, those varices that you see in the case of cirrhosis are actually a very thin wall, meaning it does not really take much trauma to actually break through those vessels. And what happened, once those vessels broke, these are veins, so they will not contract. The bleeding that may happen may actually be massive, may kill the patient itself. Also, infection, with the involvement of the liver with so many, components, of the immune system, when the liver is gone, infection is going to be also taking hold of that patient. All right, what do you see in this case? You will see the typical, findings that you see with biliary kind of, disorders. So you will see that the ALK-phos and the GGTP, the gamma glutamyl transferase, are going to be increasing. Why? Because they are actually in the biliary epithelium. And when there is any kind of insult to the biliary epithelium, those actually are going to find their way into the blood, and they are going to increase. You're the good doctor, you look at them and you will see that there is a stark increase in ALK-phos and also in GGTP. That's one. What happened actually, the bile is flowing into the rest of the liver. what happened to the liver cells in this case? They will be dying as well. So you will see that the AST and the ALT are going to increase as well, okay? But their increase is not going to be as, as stark as you see, for example, with viral hepatitis, okay? So there's what you call pattern testing, when you see that the start of the process are actually the ones that are related to biliary obstruction, in this case, alphas and GGTP, and less increase in AST and ALT, you know exactly what the etiology is going to be, and in this case, it's going to be biliary obstruction. If it is the opposite, meaning you will see that the ALT and the AST are the most increased, but at the same time, I mean, you cannot escape. The liver is, still an organ that is in direct continuity with each other. You will see also that the alphas and also the GGTP will increase in, let's say, viral hepatitis, but the increase is not going to be that much. You see what I'm saying? So you look at the stark increase of those enzymes. If it is related to the biliary obstruction, you know what the etiology is. If it is related to hepatocytic kind of injury, it's going to be more related to viral etiologies or other kinds of etiologies and related to biliary obstruction. All right, so it is an autoimmune disease. One of the reasons they figured out that it is an autoimmune disease is when they started to look and see, the autoantibodies that are present in those patients, including, the AMA, the anti-mitochondrial antibodies that are directed against the mitochondria of the hepatocyte of the liver cells. Okay. Present in 90 to 95% of patients with PBC. The kind of inflammation that you will see is going to be in the form of, you want to call it invasion. It's not really invasion, but there will be seas of plasma cells and lymphocytes that are going to go through the bile duct, okay, in the portal triad. Now, not only this, but you may start to see also some granulomatous, non-caseating granulomatous inflammation, which is a testament to the autoimmune nature of the disease. Here's an example of that, where you see that this poor bile duct will soon be no more. Why? Because there is this sea of this, lymphocytes right here, and you have to trust my word and take it, and believe that there are others, actually plasma cells. In addition to this, you start to see that there are what you call epithelioid histiocytes, larger than what you find in this lymphocytes. Epithelioid histiocytes that are actually the most important cell when it comes to the diagnosis of granulomas. Okay, it is non-caseating because you don't see any kind of necrosis that is nearby. Right. Eventually, this region, this portal tract will become destroyed. Remember that the process is happening in other portal tracts as well. So there will be first what you call triaditis, in this case autoimmune triaditis, and then it will start to link each other. It will spill over outside the portal tract and into the lobule, and will start to connect in nearby portal tracts, is resulting in what's known as a bridging necrosis first. That will be healing by fibrosis, and that's going to eventually result in the formation of cirrhosis. On the other hand, primary sclerosing cholangitis, remember a very important relationship for PSC, the most important relationship. أيوة دكتور. صباح النور، كيفك دكتور؟ يا هلا. يا هلا يعني خلال دقيقتين بيكون عندك. إنه معي هلا. يعني هلا بيخلصوا من هنا وبيكونوا عندك خلال دقيقتين ثلاثة. اوكي يا هلا. Right, this is Dr. Atar Bassas. So you guys are done. We'll finish this online. How about that? Okay? Or if you can spare an hour for me.
Online.
This is what I like the most. Yes. No problem. I tried to finish. How many slides left? Wow, only 15 slides.